African American Legends highlights the accomplishments of blacks in areas as varied as politics, sports, aviation, and health. We will explore how African Americans have succeeded in areas where they had been previously excluded because of segregation, racism, and lack of opportunity. I'm your host, Dr. Roscoe C. Brown, Jr., and joining us today is Eugene McCabe, the president of North General Hospital, which is an institution in the African American community because it has survived and it is serving the community of people of African American descent as well as other groups. Gene, glad to have you with us on African American Legends today.
Thank you for having me.
And as I said, North General Hospital is a legend, and as the president, I guess that makes you a legend as well. But would you tell us just the story of North General? How did it get started? What are its objectives? And how is it doing?
I have to smile when I'm asked that question because, as you know, Dr. Brown, we had a very checkered beginning as North General Hospital back in 1979 when we began. And I think the idea and the difficulty there was because we didn't have a particular plan for launching a private voluntary community hospital for Harlem. And as you know, because you were involved in a lot of this, we worked very hard, I think, trying to develop a coalition of people who would recognize that the hospital deserved a chance. And
key word is community.
Key word was community and coalition, because what we had was a coalition of community figures, political leaders and civic leaders and religious leaders and others, business leaders as well, who recognized that a hospital is a very important part of a community. And you're not really going to have a burgeoning community like we thought Harlem could be without a good hospital, and therefore we began with that community help and with that coalition.
Now, we do have Harlem Hospital in the Harlem community, a public hospital. What is the interaction between North General and Harlem? Where does North General fit into the matrix of health services in Harlem?
I think, as you know, if you look at, when you look at our neighborhood, you see that we don't have very many private physicians. And so the hospitals, both Harlem Hospital and North General, serve sort of as the community physician for Harlem and East Harlem and some of the areas of Washington Heights. We look at Harlem Hospital as a very key element in the health delivery system, and we believe that Harlem Hospital is a very vital institution and needs to be saved. Our focus primarily is to try to develop a program that deals with both the realities of service that we need now for a community that, from a health point of view, is underserved, and also, I think, equally important, trying to develop a plan for how we're going to exist in this new healthcare system and what kind of services we're going to provide and what are we going to be as an entity.
I think you were a little too modest in describing the genesis of North General. North General was created by a group of leaders, including Randy Guggenheimer.
That's right.
Who had been with the old Hospital of Joint Diseases, which
Yes.
was 124th and Madison Avenue in
Yes.
Harlem.
Yes.
And when Joint Diseases moved downtown,
Yes.
this group headed by Randy Guggenheimer and others
Right.
said, look, we're going to continue to serve the Harlem community with a community-based hospital, and he recruited the genius of Gene McCabe. And then Gene McCabe and others worked with the political establishment and the business establishment and the healthcare establishment to not only keep North General alive, but to build a new building. Tell us about the new building. How did it come about?
I think the idea of genius in our hospital was basically the plan that we all put together and hard work and determination, because that's what I think genius is in a sense. What we decided was that we wanted to have a hospital that worked in Harlem, and that meant that we had to have real key services and those kinds of services that worked. And so we began in 1979 to develop what we called a strategic plan, and that plan focused on what should the hospital be, what kind of services should we offer. And so we decided to focus on primary care. And so we have about 100,000 clinic visits in our hospital each year. We have about 30,000 emergency room visits. And so it was in that way that we began to develop, I think, a niche for the hospital and a recognition in that community that we were sort of a vital link in this healthcare chain to serve this neighborhood.
And then, in terms of the funding for the new building and the design of the new building, which is really very interesting, how did that come about?
Dr. David Axelrod, the former health commissioner, who I think was a visionary in many ways, and he spoke all the time of having a healthcare system of equality and parity. And towards this end, he developed a program where hospitals like our own, which if you look at our balance sheet in 1985, we wouldn't have been able to go to the bond market to get the conventional kind of financing that hospitals get. So we put together sort of a creative financing plan, and we got $150 million in tax-exempt bond financing. And with that $150 million, we were able to do several things. I think most importantly, we were able to restructure our debt. You know, you hear a lot about debt restructuring now in business. And we had some obligations that if we had carried them on our balance sheet, would have basically, the hospital couldn't have functioned no matter what kind of building you were in. So we restructured the back debt. That was very important. And then we decided to build a building that fit in with our community and neighborhood. And I think the most important selection in that process was we chose an African-American architect, Alexa Donovan, to design our building. And our building has won many architectural awards, and for 1991 was one of 4 most successful construction programs in New York State, as designated by the Contractors Association of our state. And that was very important because I think that it was a very successful program. We saved enough money to build another office building on 119th Street. But equally important, I think, both from the point of view of the people within the hospital and the people that we had to deal with, I think our credibility was established as people who understood business, who understood the use of finances, and understood how you could create, you know, the kind of package that you had to do. And we think this was a very important development in getting people to recognize that we do the same things in Harlem that people do everywhere.
Now, in addition to the hospital and the office building for administrative and sometimes physicians' offices, you have gotten into the housing business. Now, how does a hospital get into the housing business?
As you know, if you look at, you know, we used to describe our neighborhood in some way as a wasteland, you know, because if you look at our neighborhood, in 1979, you had the old hospital on 124th and Madison, and then you had 4 or 5 blocks of just
vacant land.
Vacant land. And our feeling was that if you're going to spend $150 million to build a new hospital, then certainly that should create the opportunity to build out from the hospital and help the neighborhood. So we began about 6 years ago developing a housing program, and we ended up with some, again, another one of these packages of financing that wasn't sitting on any table, but that had to be sort of designed and thought through. And so we developed a home ownership program where we have 135 co-op units right next to the hospital, and I'm pleased to say that these units are sold out, and that in 2 weeks the people will be living in those units and owning them. And we think home ownership is a very important part of what we do. And I think fortuitously we got another grant from the city, and we're going to build another housing complex right next door to the one we have. And if you look up and down Madison Avenue now, there are about 4 or 5 blocks where you have housing or office buildings or other kind of structures which we think bring a kind of vitality to our neighborhood, and we think get people to recognize that the hospital is more than just a hospital. I think any sort of African-American entity has to be something more. I mean, it's one thing to be a good hospital, and I should add that we focus on excellence. You know, we have a group of people who are very hardworking and very intelligent and understand the system.
And are very dedicated to dealing with the people in the community. Having been there, I can say that.
I think so, because in some ways we are the community. Mm-hmm. And we certainly would like to think that we consider ourselves, you know, we ask everybody to work real hard, and in doing so we say we're a family, you know, we're all working together. But in many ways the patients and our neighbors in Harlem and East Harlem are also part of our family. Mm-hmm. And we think the most important thing when you come into a hospital is to have some sort of idea that there's a sensitivity for the feeling that you have. Either you're sick or someone that you love is sick and you're looking for help. And we think this sort of environment in that hospital when you come in and how you're treated is a very important part of what you recognize as good health care, and also we think this lends itself to better treatment and people getting better faster.
About your staff, what is the ethnic distribution of your staff? Where do you recruit your staff? How good are they? I know you say they're plus, but just have some conversation about your staff.
We have, and we just did a survey, so I can say that we have about 64% of we have in our hospital about 1,000 employees. About 64% of them are African American. 20% are Latino, and then the remaining we have 10% white, and the remaining are Pacific Islanders and Asian Americans. And we think that's very important because in many ways, if you look at our hospital, which you could describe as kind of a mini United Nations, it's different than other voluntary hospitals in our city because the leadership has people of all kinds. And if you were to call a meeting of the leadership at our hospital, you'd have more than half would be women. You'd have African American, Latino, Asians, and others all sitting at the table trying to decide what the best thing for this healthcare institution should be. And I think that's very important. And we're very lucky because we have a pretty good reputation. We get lots of young people who want to learn how to get things done. Some interested in hospital business, some interested in finance, some interested in housing, who come there and use our hospital as what we like to think it is, as a kind of laboratory for this one single point that we think is very important for us to recognize, that it's good to have wonderful ideas and it's good to be able to plan, but it's most important to get things done. And we consider our hospital as a place where we get things done.
Of course, as you talk, you understand the genius of leadership. You are recognizing the importance of involvement. You're recognizing the importance of relating to the diversity in the community. So the question I want to ask you is, why don't more hospital leaders think the same way Gene McCabe thinks?
I think that part of the thinking that we're talking about was fueled in that cauldron of how we got started. You know, I mean, we got started in a situation where it wasn't certain that we could maintain this hospital. And I think because of that, we grew a kind of esprit de corps, you know, where people recognized that every individual in our hospital had a role to play. And it wasn't just what I did, but it was what the doctor did, and what the nurse did, and what the housekeeper did, and what the food service worker did. And I think in developing that kind of esprit de corps, you know, we have what we consider leadership throughout the hospital, because it doesn't matter what one person does. But what it does matter, where it does matter, I think, if you have the kind of cooperation that comes from we used to talk about having a dream, but not just having a dream, but having a good idea that's based on some degree of reality, and having that reality sort of be this feeling that there's not a darn reason why you shouldn't have a hospital in Harlem that's as good as any other anywhere.
Of course, that's the spirit of African American legends. Each one of the legends we talk about, each one of the institutions strives for that kind of excellence and that kind of understanding of how African Americans survive in the complex society which is racist oriented in which we live. Now the hospital, we have the hospital, but it's there for a purpose. It's there to deal with people who have health problems. What are the health problems that confront the African American community in the main, both in New York City and nationally?
I think a lot of the health problems we have come from our lifestyles and the way we live. I mean, I think that there's no question but that African Americans, we smoke more, you know, we tend to drink more, and our nutrition is something that we don't always take into account, you know, the health.
Tastes good, but it may not be good for you.
It may taste good, and it's not always good for you, although we know that most of the time it is good. And then in some ways we live in communities where the environmental situation is also fraught with some kind of danger. And so we have people that show up at our emergency room and in our hospital, and in many ways they haven't seen a physician for a long time, so they have some kind of end-stage situation. We have cancer at a higher rate. We have African American women have breast cancer at a rate 3 times that of the general population, and we have prostate cancer, you know, more than anyone else. The whole issue of AIDS that you've had several shows on focusing on AIDS in our community is creating a terrible problem. We have all the kind of we have problems of low birth weight babies. We have all the issues. We have drug abuse. We have all the kind of things that reflect our position in society, where in many ways we're kind of shut out from some of the ways that other people use to be healthy, which in many ways are undergirded by an economic ability that we don't generally have.
And of course, hypertension and stroke are very high in the black community. And some say that's genetic, some say it's because of the diet and the salt, and some say it's because of the stress that African Americans live under. It's probably a combination of all three. Now, as you organize your hospital to deal with this myriad of problems, the breast cancer and the nutrition and the hypertension, the cardiovascular, et cetera. How do you organize your hospital? I noticed you mentioned earlier that the emergency room, the clinics, are your basic point of intake. Now, going past there, how do you organize the hospital so that it can attend to these particular problems?
I think we have a women's health program that focuses on a lot of the cancers that our community are susceptible to. We have other operations and clinics where we do outreach for some of the population that would deal with diabetes and hypertension, as you talked about. What we try to do is to bring the services out to the neighborhood. One of the difficulties we have, of course, is that the way hospitals are presently financed, you only get paid for a lot of the services that are within the hospital walls. And so so part of our job in some ways is to create lots of activity within the hospital, because there's more revenue produced from that activity. But we feel it's very important to sort of get outside and get people to recognize that you can improve your health, you know, by doing things, by exercise and by stopping smoking, those kind of things. And in many ways, that's the message that we need to bring. I mean, for example, a lot of the children that have babies, and many, as you know, many young women in our community do have babies, they never go to anybody in many cases until the baby is basically ready to be born. And what we're trying to do, we have a program at one of our satellites where we go out and we go to schools and we go to community centers and we go to housing projects and other places where we try to identify young women who need prenatal care, and then we bring them into our center and deliver that care. And we've had a tremendous success, I think, in that program. And we weren't surprised, nor were we shocked, but the idea was that that service wasn't really being provided for in our neighborhood in the way that we thought was necessary to really affect that problem.
Now, much of health care is dependent upon availability of money as well as availability of services. And there are some things on some of the reform agendas to alter Medicare in particular. And a number of people in our community feel that that's going to be antithetical because it's going to cut out a lot of folks and make it more difficult for people to get the medical attention that they have. One of the things that I observed the other day is that it's generally agreed that with the advent of Medicare some 15, 20 years ago, the life expectancy of African Americans has increased.
Absolutely.
Not as much as white Americans, but it has increased.
Absolutely.
And more people are
It's still
getting
much lower
care.
than the general community, though. And
It's still much
that's
lower.
part of what we're talking about.
But so therefore, how do you evaluate these proposed changes? The allegation is if we don't change it, Medicare will go bankrupt in 2008 or what have you. Some others say that the reason why this is being projected is to support a tax cut, which mainly is for upper income people. And since most African Americans are not upper income, that tends to say it's on the backs of the poor and the minorities.
Right.
But talk specifically about the changes and then what you think the changes will do if they're allowed to go through.
I think I always begin this kind of discussion by pointing out that if you look at the health indices for places like Harlem around the country, then as you say, our life expectancy is less. You know, we have all the diseases at a much higher rate than other people, and low birth rate babies, and on and on and on. So I look at the present system as one that basically has a lot of room for improvement. And it always seems to me that one of the things we have to try to figure out is how can you do better. And certainly when we talked about the issue of health reform in the context of the Clinton plan last year, the idea was that one of the things they were going to do would be to make the 37 million Americans at that time who were uninsured. These are people who work every day, you know, and have families, but don't make enough to be covered, and their jobs don't cover them. We were going to provide for that population, and I thought that was going to be a real beginning towards some kind of continuity of health care for that group. Well, now that 37 million is 40 million, and we're talking about something entirely different. And I don't know where the revenues are going to go from some of these cuts we're talking about. But certainly the issue of managed care is one that has to be looked at, I think, in this context.
Well, let me ask the question. I gather that there's a feeling in this Medicare reform to, instead of just giving everybody a card and they can shop around, to organize health care into health maintenance organizations, private practice organizations, et cetera, so that the extent to which the public can use health services is determined through this screen or through these organizations, and thereby hopefully saving money. In addition to which, I understand they want to cut the fee structure for the physicians.
I think so. I think if you look at it, if your focus is on saving money, if you want to reduce the healthcare expenditures, and you say that managed care is going to accomplish this, then what you're saying is that basically you're going to change the way you finance the system and expect that that will be cheaper. But one of the things people don't talk about, when they talk about managed care, is what's going to happen to the people who aren't covered. If they're talking about managed care, and it seems to me that a lot of the budget projections that I've been seeing out of Washington, have some kind of like flat rate of increase, and we know that people come on all the time on the Medicaid rolls all the time, And
Medicaid or Medicare?
Medicaid. They come on the Medicaid rolls and the Medicare rolls. I mean, we're all getting older,
Could you explain to the audience the difference between Medicaid and Medicare?
Medicaid is a program for people who fall below the poverty line, and this would cover all of your health benefits. And in New York State, for example, last year New York State paid out about $22 billion in Medicaid benefits, but we have to recognize that about 2/3 of that, 70%, went for nursing home care. So it didn't go to just, we hear so many things about how welfare people, take advantage of the system. So Medicaid is really a program that supports the middle class because it supports nursing home care for patients in nursing homes. Medicare is a program that at 65 you're eligible for, and then in most Medicare programs have a kind of copay. So in most Medicare
copay means that the user pays some money.
The user has to pay some money. Usually there's sort of a gap between what Medicare pays for the doctor and for the hospital, and then you're asked to pay that difference. But it's a very generous program, and I think it's a program, as you indicated, that's really had a big impact on longevity in our community. And what's happening here is that the talk coming out of Washington is that healthcare costs are growing at this exponential rate, and we have to cut them, and therefore we're going to cut Medicaid and we're going to cut Medicare. We're going to make a managed care program for both programs, and we're going to do this for less money, make it more efficient, and improve the quality. And
what about the uncovered population? People who don't qualify for either Medicaid or Medicare.
Well, a lot of the debate's not focusing on that group, but just think about it. We have about 30,000 emergency room visits in our hospital each year, and probably Harlem Hospital has 150, and you could take this to every hospital in New York City. About half the people who come into our emergency department don't have any coverage, and so what happens is that we have to bear that burden. And we get help from the state and even help from the federal government.
But with the new regulation, they may cut that out.
Well, we know that the disproportionate share, for example, for hospitals like our own that come from Medicare, for example, every time you serve a Medicare patient, you get an add-on to take care of those people that can't pay. We know that's been cut by 25% in this program that we see coming out of Washington. There's no real debate about the uncovered. I mean, it's almost as though that population is invisible. And the assumption is going to be that when this new program is passed, that they're never going to come to hospitals, they're never going to come to clinics, and they're not going to require physicians.
Well, as this dialogue goes on, we're back in Harlem now. We have unmet needs in Harlem. We have several institutions. We have Harlem Hospital, we have North General, we have Greater Harlem Nursing Home.
Yes, we do.
How do you think we can restructure healthcare in the Harlem community in the context of all these changes that are going on?
I think the first thing that needs to be done is something that you've been working on with us, and that is that we formed an alliance together, and that alliance is going to, we believe, is going to allow us to transfer patients more efficiently, reduce costs, merge some of the back office and support functions and things that we do. So I think that's a very important beginning. And in my mind, that should be the nucleus for a program where all of the healthcare providers in our community would be linked in some way. That would be Harlem Hospital, a lot of the private physicians that are there, and some of the clinics as well. I think one of the most important...
And Greater Harlem Nursing Home, where I have the privilege of serving as chair of the board.
Yes, you do. Yes, you do. And I think it was your vision that saw that there ought to be some sort of coming together to not just to save money, but to have two better and efficient and more efficient operations. We think that, and it becomes almost a cliche when you talk about it, but we think this idea of information systems and is so important to hospitals, because one of the things that's going to happen in this new system is that you're going to have to be able to track patients where they go. And we're trying to, in working with you, trying to develop an information system that we have in some doctor offices that we're linked up with, where any patient that presents himself at any of the entities that we have, the doctor can call it up on a computer screen, and you know what drugs the person is taking, what tests the person is taking, so you don't have to do all these things again. And we're also creating a database, and what we're trying to do is to make our community sort of a laboratory for this kind of cutting-edge information system, and in some ways, get people to recognize that you need to help support that kind of operation, because it's got like the nucleus for finding out how much things cost, where people go, and how you can sort of maintain some kind of continuity in all of this.
Well, of course, the interesting thing is the match between technology and need. And one of the concerns that some people have is that technology will call the tune to such an extent that the human needs of people will be bypassed. What do you think about that?
I think philosophically that could be true, but I think that in the world that we have now, what you have to know is, for example, at Greater Harlem Nursing Home or at our hospital, what does it cost to provide service to a patient? What's the unit cost? How much do drugs cost? What's the cost of the doctor service, the nurses service? And if you're not able to really establish those costs, then you're really sort of isolated, because you really don't know how much what doing business is going to mean to you. But more importantly, though, I think that what we can do is, if we can track patients across the spectrum, then we can find out where they're utilizing care, whether or not this care is efficient. Because the most important thing that information can tell you, from our point of view, is that it can give you outcomes. That is, when you were sick and you came into the hospital or the nursing home or the Paul Robeson Clinic or some of the doctor offices, did you get better? And if you got better, how long did it take you to get better? And then what was the cost of that? And it seems to me that people always say, well, healthcare, for Harlem residents is more expensive than it is in other places, because, because we access the system so late and we have some of these other problems. And we say maybe that's true, maybe it's not true, but let's get the data and find out.
Okay, I think with that kind of insight, healthcare in Harlem and everywhere will get better. And I also think that under your leadership, North General Hospital and the healthcare system in Harlem and in the state will be better, and hopefully there are more people who think like Gene McCabe, and there are more hospitals like North General that provide the type of community-based care. Thanks again for being with us on African American Legends. Eugene McCabe, North General Hospital.
Thank you.